Hi, I'm Josh McDonald.
And I'm Miranda Materi, and we are Hand Therapy Academy.
Let's talk a little about skin grafts, about what the types are, what we do with patients who, when they come in the door, who have them, some of the options that are available that may walk in your door. So, talk about skin grafts. So, Miranda, talk about maybe some of the different types of skin grafts that you may see come in.
Yeah, so I think this is, you can see a range. You can see anything from a partial thickness to a full thickness. So basically, a full thickness is when they take the epidermis and the dermis, and then a partial thickness is where they take the epidermis and part of the dermis. So it's just not quite as thick. And there's different indications for doing the different types of graft. I would say, like, a full thickness skin graft is usually in an area that's probably going to be. Where you'd want to do it where they might be more likely to contract, because the partial thickness ones are more likely to contract and come in. I mean, both of them will contract, but the full thickness is less likely to. So that would be an indication. Also, cosmetically, a full thickness one looks a little bit more cosmetic, like our own true skin. And it is our own true skin, but it doesn't look like you've had skin removed and put back. So it's a little more cosmetically pleasing. Now, when you get into partial thickness skin grafts, you can have either a sheet graft or you can have a meshed graft. And these are all autografts. So we're just talking about autograft. Autograft means it comes from the patient's own body, right? So they'll harvest them. Like when I worked in the burn center, they would always harvest them usually from the thigh or wherever there was healthy tissue. But it was mostly the thigh. I think that's an easy place for it to get at. And you're not like really usually laying on your thighs. So it's a pretty good area, and they're not, and your thighs aren't getting a lot of sun exposure as well. So they basically will remove that layer, and then they'll either use it directly, or they'll mesh it and spread it out. So if they need more skin, they mesh and spread it out more. So like the bigger burn patients are getting probably more of the meshed grafts, versus if it's just like the dorsum of the hand, they're going to try to do the sheet graft, because it matches more to your original skin. So depending upon how much coverage is needed and where the graft is needed, goes into that decision making process.
Yeah. And there's another type of graft you may see that I feel like is way less common, but it's a pedicle graft. And that's a graft where they maintain the blood supply intact and it stays attached to the skin. So typically, it is they take an incision and do a non-closed loop. So like think like a keyhole shape where it stays attached at one end, and that's where the blood supply comes in. And then they pick it up and rotate it to the recipient site. So wherever the donor site is has to be immediately next door, and so they pick it up and rotate it, keeping that blood supply intact and just pivoting the skin around that, and then attach it to the recipient site.
And so, what would you say, just so our audience knows, why would a patient get a pedicle flap versus just a full thickness skin graft?
Yeah. A lot of times it has to do with their vascularity and their ability to heal. Are they a good healer with good blood supply, good vascularity, or are they struggling with it? I had a patient who was a young, healthy guy, and he was just a bad healer, and we could not get his zone 2 index finger flexor tendon to close. They tried split thickness skin grafts or partial, same thing. They tried different versions of skin grafts, and they just kept failing. So the doctor tried this pedicle where the dorsum of that second ray over the metacarpal, they just took a like keyhole shape, left it attached over the MCP, and then with that blood supply still intact, pivoted it around the MCP and attached it over that, like kind of wrapped around the corner over that volar aspect of the finger. And that survived and was viable long term. It ended up being not as mobile a skin tissue when he needed to flex and move that finger, but it was better than an open wound that just would not heal with other grafting options.
Yeah. I would be curious, how long did you immobilize that for, or how soon was the patient moving?
Yeah. Because he was a bad healer and we were on kind of like not really salvage mode, but we were on like this is our last option for things because he kept rupturing open and going necrotic on skin grafts. We were much more cautious on that. So we talked with the surgeon intimately on this one, and we said we would love to get him moving as early as we can. And he said, I want to get eyes on that before you move it. I'm going to see him every week. And when I give you approval, like, yes, it's stable, then you can move him. So we immobilized him and stopped seeing him for, gosh, I think it was 2 weeks of 1 week follow up. At the second week follow up, doctor said, okay, now it looks viable enough for you to go ahead and move it. Just because he was such a bad healer, this is kind of our last option on the table for a normal graft healing process.
Yeah, that's interesting. When I worked in one clinic, we had a surgeon that would do a lot of the radial forearm flaps.
Okay.
So basically taking, the tissue from the forearm and rotating it around and putting it over the dorsum of the MCPs. And it was usually when people had basically contractures where they were in that intrinsic minus position. So he would do a capsulotomy and do the radial forearm flap and put it over. And this was after having a burn injury.
Okay.
But what was interesting is we always would usually hold off on doing any movement for 2 to 3 weeks. That might have changed. I haven't been there in a while, but I know we'd always wait a long time on the flaps.
Okay. And so let's talk about some of our other kinds of flaps and timelines. If you had a patient with a full thickness skin graft, how long would you wait to get them moving?
Yeah, so the caveat, of course, is what your surgeon prefers. The literature says 5 to 7 days. One thing I always tell students and new therapists is making sure that you're taking the dressings down and watching them move to see what that skin graft is doing, right? We want to make sure that it's adhering and that when you're moving it, how much stress is that joint putting on it? So I think it can be really helpful for them to take it down and watch them move. So full thickness skin grafts is 5 to 7 days, though. But make sure you take it down and watch them move. And if it crosses a joint, that puts more stress on it. So we want to make sure that it's well vascularized.
Okay. And then for a split thickness or partial thickness skin graft?
Yeah, and partial and split thickness, we didn't say this, but those are basically used interchangeably. That's 3 to 5 days.
Okay.
And then you might ask why. Why would you immobilize a full thickness skin graft for longer than a partial thickness? And that's because the partial thickness ones are more likely to adhere than the full thickness ones.
Yeah. Yeah. So let's talk about some of our skin substitute options, because sometimes patients come in and they have this other product on them, and it's kind of a two-step process. And the most common of that is Integra, and it's a clear sheet. There's oftentimes a line across it because it comes in a big sheet, and then there's like I would say grid line, but you don't see the grid, you just see a single line. Almost looks like the hair on it because it's so faint. But they put that over top of the recipient site. And that allows them to watch for the repopulation of the dermis granular tissue underneath. And so initially that patient comes in and you can see everything. It's like a window to their tendons, and you can see everything moving and gliding as long as you're within the doctor's recommended guidelines to view it and move it. And then as it gets cloudier, you know that that's populating with granular dermal tissue in that subdermal layer. And then once it's usually about 2 weeks, 2, maybe 3, you get to a point where it's really opaque and you can't see much underneath. The doctor will then do most likely split thickness skin graft because they have a good bed of the dermal tissue underneath that they don't need to do a full thickness anymore. And that's usually reserved for larger surface areas because you don't want to take a giant full thickness skin graft because it will retract and you lose functional movement, all that kind of stuff.
Right. So I always say, think about the Integra as being a skin substitute. It's a skin substitute while the wound bed gets prepped for an autograft. And so another thing you can use besides Integra would be allograft. So allograft is basically coming from another person or cadaver tissue. And then another thing that you can use is xenograft, and that is usually from a pig. So there's different things you can use to prep the wound bed for the autograft. So like Josh said, it could be Integra, it could be allograft, it could be xenograft. Those are all options.
Yeah. We cover a lot of this kind of stuff in different parts of our Hand Therapy Academy platforms. We do have some good content on wound care. We have a whole course on wound care strategy. So if that's something you're interested in, we have a standalone course, or it comes free with our Pro or CHT Prep memberships in Hand Therapy Academy. So if you're interested in any information or have any questions, reach out to us at info@handtherapyacademy.com or on our social media platforms at Hand Therapy Academy.